What is a placebo and nocebo effect?
Well, so placebo effect is defined as the positive effect of treatment that cannot be attributed to pharmacological action of the treatment itself and can be rather attributed to some other psychological mechanisms, for example, expectations. And the nocebo effect would be the same, but negative treatment outcomes that cannot be explained by the treatment.
Okay, and what role does classical conditioning have in these two effects? Because I find that very fascinating that there's some pairing pairing system between the environment and someone's expectation that kind of creates this belief.
Yeah, so that's definitely very, very interesting. So there are several ways we can induce a placebo and nocebo effect, and also how they get induced like in real life. So that can be just pure psychological expectations. So, for example, you're getting a new treatment and you're really anxious to get side effects, and you might develop them. So that's a pure expectation. There was no conditioning, never nothing was coupled. You never tried this treatment before. So that's one way. But another way is when you get conditioned, and conditioning means that there is coupling between an, for example, treatment and the outcome. And a good example for that could be headache, because we all experience headaches. And when you usually get a headache, you can go and take a Tylenol, and your headache disappears. And you've done it many times in your life, so you are actually conditioned to get this certain pill with a certain color and then experience a pain relief afterwards. So there's a really high chance if right now you develop a headache and I'll give you a placebo Tylenol, and that will look like real one. You take it, probably your pain will also disappear. So such a placebo response that is developed through conditioning, through the pairing, is considered to be caused by conditioning.
Okay, and how does that work for the nocebo effect per se?
It can be the same. So, for example, if you look at clinical practice, like the very strong nocebo effect can be described, for example, for chemotherapy patients, because chemotherapy elicits very strong nausea. So, like a day or 2 days after you get chemo, all people get like really, really strong nausea. But what's been found that people often start developing nausea before chemotherapy just by coming to the hospital, because they have this association. I come to a hospital for chemo and then I get like really, really nauseous. The whole environment of the hospital can trigger that. So it would be also a conditioned nocebo effect in this way.
Okay, so essentially what you're saying is that there's this coupling effect really drives someone's psychological state and in turn their behavior as well, and there it doesn't have to. It's independent of the intervention that's going on. Correct?
Exactly, yes. So
Okay.
often intervention is present there, but the effects are not really effects of intervention, but effects of conditioning or expectation.
Okay. And I assume that this happens also outside of a medical context. It's just that it's well researched in the medical context, correct?
Exactly, yes, exactly. And we can also look at placebo effect broader. For example, there are these marketing studies where they let people try wine and say that that's a very expensive wine, and then people describe then this wine as tastier. And that could be also called like a placebo effect, because it's the taste is not really taste of wine, but the taste of the expectation.
Right. And now, how powerful or effective is the placebo effect?
That's a good question, and I think we cannot really answer it right now because it's so context dependent and treatment dependent. So, like placebo effect is investigated a lot in the area of pain, and if we look at, for example, placebo analgesia, so placebo decrease in pain. If we look in lab settings, so when we are doing it in a laboratorium and it's all experimental, actually the effects are quite small. So you might have a decrease in pain approximately like 2 points on the 10-point scale. However, if we look at clinical practice or we look at studies that are more like with patients, for example, or in clinic, sometimes they find way stronger placebo and nocebo effects. And I think it first of all depends on the treatment. Second of all, of course, it depends on how the whole situation is believable. Because if you're doing it in the lab and our participants like don't really take treatments very seriously, the expectations are also not so large. But if you're, for example, a patient who came to get a new treatment, your motivation is really high to feel better, and then the effects can be also larger. So it varies a lot between the studies and
Okay.
between the treatments.
And is there a point where belief and expectations can kind of expire and the placebo effect just stops working?
Theoretically, yes. Practically, again, we don't have so many studies, but we know of this process called extinction in conditioning. So what happens when you get conditioned? So for like we can go back to this example with the painkiller. You're
Mm-hmm.
conditioned that you take a painkiller, your pain goes away. Then you get a placebo pill, and it does work. But then imagine you get next day you have headache and you get the placebo pill. Next day you get headache and you get it again. So probably at some point your body and you also will notice that it's not working so strong, and this placebo effect will disappear. And so that does happen. Also in experimental studies we see that. And for example, for my own research, I had a study with oxytocin when we tried to induce this oxytocin release with placebo. And we did it during 3 days. And on day one, we saw a large placebo effect. And already day two, it was insignificant, but you could see some difference. And day three, it was completely disappeared. So basically, when your body sees that actually this link doesn't hold, the effect disappears. But
Okay.
also maybe important to say that what we find look at, when we look at pain, we see that this extinction doesn't happen so fast for nocebo as fast as it happens for placebo. So unfortunately, the good effect disappears faster than the negative one.
Do we know why that is? Is it just because like stress is very stays in the body longer than I guess higher expectations?
I think so. That's a reason. Probably, if you look at like at evolutionary purposes of nocebo, they might be more like they might be stronger, more important for the body because if you associate something with pain, it's like probably a very important association. You want to avoid this object, so you remember it longer. While when
Okay.
we talk about placebo, yeah, it's good, but like yeah, how it's not so vitally important, probably.
Okay. And then does that mean that the placebo effect is both a cognitive thing and a memory, like a phenomenon, or is it like independent?
Definitely. Yes, I think it's both, and I think it's very hard to put the line what is cognitive and what is memory, what is just belief, and because, for example, there are studies where placebo effect is induced just by giving positive information. So you
So
might
verbally.
think, yeah, just verbally, yes. Or observational learning. So you see other people improve from a treatment, so there is a higher chance you will improve. But then there is also some learning underlying it. So you do remember what you were told, or do remember what you saw before. So.
Okay. And can animals also experience the placebo effect?
Yes, they can. And I think like many people find it really fascinating because when we think about placebo and expectations, we think about, of course, humans. And it does happen in animals. And of course, we cannot give verbal information to animals, but what we can do, we can condition them. And
Mm-hmm.
conditioning works pretty well. And there are multiple studies in pain, but also studies in other areas, for example, with different drugs. And animals seem to get conditioned pretty well.
Okay. And for someone who's never read an animal studies paper on nocebo or placebo conditioning, how would you condition an animal to experience either placebo or nocebo?
Okay, so we can look, for example, at placebo, and these paradigms are usually called pharmacological conditioning. So you can teach an animal associate feeling better from the pharmacological agent, and that would cause placebo. So there are studies where, for example, a mouse is given an treatment like opioid drug that reduces the pain of the mouse, and then the mouse might be placed, for example, on a hot plate, and that's how we can measure the pain response. And then after getting the opioid treatment and being placed on the hot plate, mice, of course, experience less pain, and then they jump off the plate slower. And then after several administrations of this opioid treatment, we can replace the opioid with a placebo treatment. Often can be injection. So instead of injecting an opioid, we would inject the saline and then put the mouse again on the same plate. And what we see, the response to the hot plate with this saline would be similar to the response as if the mouse received the opioid treatment. And for nocebo can be very similar. So a mouse or a rat can be given some painful stimulus in certain environment, and then after repeating coupling this environment with the painful stimulus, just placing the mouse in the environment alone would elicit higher sensitivity to pain.
Okay.
So it's always a coupling with some environment or process of drug administration with the stimulus.
Okay. And do we know what are the differences? Like how much more sensitive to pain do the mice get, or how much less sensitive to pain do the mice get, just based off the study paradigm?
Yeah, so actually, if I look at our studies, the studies we did at McGill, the effects for mice were quite large. So we were investigating nocebo effect and pain, and with by a coupling environmental context, so the special cubicle where mouse would be placed with the painful stimulus. And what we found, I think the pain would increase maybe like 30%. So it's actually higher than what we get from humans lab studies.
Right, and also just to clarify, the pain that we gave to them wasn't very painful, like by other stretches of the imagination. It was, heat pain, which is obviously it can be painful, but it wasn't as intense as like other things that you can definitely do to an animal. So 30% is very
Exactly.
large.
Yeah, it's very large considering also the stimulus. So what we did, maybe to clarify for the listeners, what we do, we have this device that shines a light on the paw of a mouse and it slowly warms up. And the moment when this heat becomes painful, mouse moves the paw. And we can measure this response time, how fast they move the paw. And if there is analgesic effect, so if pain is decreased, mouse can hold the paw longer in one spot. And then when it's opposite, if there is a nocebo effect, hyperalgesia, then they move it faster.
Right. So we're measuring the withdrawal time in that instance.
Yes.
Okay. And what does the neurochemistry of the placebo and nocebo effects look like? Because I don't think I'll never not be fascinated by that phenomenon actually being tracked like neurochemically.
Definitely. So, what many people imagine, especially when talking about placebo, nocebo in humans, that it's completely psychological phenomenon and there is nothing in the body that changes. But also, what I find the most fascinating about the whole phenomenon is that we do see changes, physiological changes. And I think the chemical processes really are linked to the type of placebo, nocebo we're talking about. And the most what we know comes from pain research. And what we see that from animal studies, from brain imaging studies, and from pharmacological studies. So there's a lot of evidence that when a person experiences placebo effect in pain, our brain produces endogenous opioids. So, what happens actually in response to the expectation or the stimulus or the treatment, our brain starts producing our internal endogenous painkillers. And due to this endogenous opioid release, the pain goes down. And that was also confirmed in animal research. And then for the nocebo effect, it's more complicated, and especially for humans because there is not much research done. But one chemical we could track in nocebo effect is cholecystokinin. And our study at McGill also showed that cholecytokinin is involved in nocebo, and when we block this neurotransmitter in the brain, then animals do not experience nocebo effect.
Right. And could you just give us a bit more context as to what cholecystokinin or CCK does?
Yeah, so that's, I think it's very interesting. It's a hormone and neurotransmitter, and we know it initially from the research on digestion. So it's like not related to pain at all, and it seemed even not to be related much to brain, because we have lots of cholecytokinin receptors in the digestive tract, and they do signal when you are hungry or when you're full. However, later on, so that was known for a long, long time. But then later on, researchers discovered that there is a lot of CCK receptors in the brain, and it wasn't really clear what they're doing there. And further on, like in the recent years, it became clearer that they also seem to be involved in, for example, anxiety and panic. And there are studies on in humans when people get an injection of CCK that they might experience panic attacks. So it seems to have several functions as many other neurotransmitters, and one of the functions might be anxiety. And that's why maybe it is related to nocebo, because probably nocebo to a large extent is caused by anxiety or fear.
Right. And so basically, just to sum it up, when you increase CCK, the anxiety and negative expectations go up, and when you decrease it or block it, the anxiety goes away. Now, just
Exactly.
to create some, I guess, distinction, is how different is CCK compared to a general anti-anxiety medication like Ativan or Xanax or anything like that? Like, could those also reverse the nocebo effect?
Good question. So there is no, so that's why we don't know much about CCK in humans, because there's almost no drugs that are can be used in humans to block CCK. There was one drug that has been used in some research, Proglamid, and but it's a drug initially made for digestion, and nowadays it's not used. And the drugs that are can precisely target receptors in the brain, they are not approved for human use. So we do not know whether if these drugs will ever be approved or developed in the way that they're safe for people. Maybe they could be used also for anxiety, but we don't know that. And then talking about using some other anti-anxiety drugs for blocking nocebo, there is actually research on that, and there is, I think, actually only one study that showed that anti-anxiety drug can block the nocebo effect in humans, but it was
Okay.
just also one study.
Okay. And what might be the, I guess, intimation that CCK might be having a greater role in the nocebo conditioning than like reversing GABA, which is what the anti-anxiety medications do.
What we look, I think it's different mechanisms, right? And we compared that in our animal models, and then we did not find any effects of anti-anxiety medication on
Mm-hmm.
nocebo in mice, even though there is one study in humans that did find the effect. But also we should consider difference between animals and humans, because in humans it's indeed the nocebo effect might be more cognitive, and it might evoke more general feelings of anxiety that maybe by blocking that goes via that route might work for humans. But when we look in the animal model, it seems that CCKs really plays the major role, because when we block CCK in animals, nocebo effect disappears completely, so we don't see anything.
Okay. Awesome. And how can one block the placebo effect?
Blocking placebo effect. I'm not sure if anyone tried to do that, because it seems clinically we want to maintain it more.
Right.
Yes, but we can. It's been done for just to look into brain mechanism of that. So what has been done is there is a naloxone, a drug that blocks opioid receptors, and that's how actually it was proposed that endogenous opioid is involved in placebo. So you can evoke placebo effect with different procedures, for example, giving verbal suggestions or conditioning. And then if you give a person or you give an animal naloxone that blocks their endogenous opioids, placebo effect disappears. So we know that that was how we actually learned that endogenous opioids play a role. So potentially, if you want to block placebo, you can use naloxone.
Okay. And just a question about the anticipation aspect of placebo, because we know that anxiety is playing a role in nocebo, but what is the emotion that plays a role in placebo? Because anticipation and expectations are more cognitive. Obviously, they're interlinked with many things, but do we know what the main emotion or main emotions are playing an effect in placebo?
Yeah, I think I can just speculate on this topic because there is like lots of studies, also studies in my lab that try to find that. We
Mm-hmm.
measure different states, like state anxiety, we measured personality, and we can never find good correlates. Here and there, something comes up. Sometimes it's like optimism, sometimes it's less anxiety, but it's never really correlated with placebo. And I don't know the reason. It could be that in general psychology, this questionnaires to measure emotions or personality are not like really good. It can be the reason. It can be another reason could be that nothing is really associated with it, but
Okay.
we honestly don't know. But one route can be that it can be still through anxiety, but other way around. Maybe it's just being more relaxed, expecting something positive to happen to you. That could
Okay.
be the route.
Okay. And what are the sex differences in the placebo and nocebo effects?
Yeah, so that's also a not very, I don't have a very straightforward answer. So
That's
if we
okay.
start looking at humans, there is a meta-analysis that looked at all studies together and compared men and women and males and females, and they found no difference. So across, if you pull all the data together, there seems to be no sex difference. There are some studies that find some differences, but it's not very convincing. At the same time, when we look at animals, we could study it more in animal model. What we found in our lab at McGill is that actually for nocebo effect, it seems that males are more susceptible for it, and but it depends on the intensity of stimuli that we give them. So in the first study that we did together with you, we found that when we conditioned mice to a context with a pain caused by acetic acid, which is injection of acetic acid in the stomach that elicits pain for approximately an hour. We found effect, conditioned effect only in male mice. And that was also done in one study before, also in our lab. However, when we changed the stimulus, we looked at post-operative pain. We found effect both in males and female mice. So I can speculate that maybe male mice are just more sensitive to nocebo, and with this less painful stimulus, they already exhibit it. But when the stimulus is intense enough, then both males and females experience it.
Okay.
But in humans, we couldn't find it. But also, I feel like there's so many other factors that interfere in this type of research that it's really hard to say.
Okay. And if you could speculate, do you think that the role of testosterone has a role to play in the nocebo effect? Because I remember when I was writing my undergrad thesis for you guys, I remember I came across this one study where they over optimized, so they removed the ovaries of the female mice and they injected them with testosterone, and then they found that these ovary optimized mice with testosterone in them had the nocebo effect, whereas the female control mice did not. So is that convincing evidence, or is that still very like early on speculative at the time?
I think it's still one study, but it is actually the study I based my further research on. And it's indeed that's what they found. And I think it has some basis. It can be the truth. And we replicated it with further on. So there's a replication of the study. But then when we change the pain stimulus, this effect is appearing both in males and females. And recently, this year, there is one human study that came out, and what they gave, it was with males, and they gave male participants testosterone cream. So they
Okay.
increased their testosterone pharmacologically, and then they looked at, they gave them pain stimuli, and they looked at the expected pain and experienced pain. And what they found that in males, testosterone increased expected pain and also increased experienced pain. So it seems that, and in that paper, they in the discussion they say that maybe testosterone is not really involved in pain perception per se, but it could be that it's involved in making people more vigilant to
Mm.
negative stimuli. Because if it makes you expect more pain, that could be that's how in the end you can develop nocebo effect and experience more pain. So I could say we can see, so there was this initial study in the mouse model, but then now there is this study in the humans. So I think it will be very interesting to look into it further, and it could be that testosterone does play a role.
Okay. Do you remember how much testosterone they were given? Like, was it a lot or was it a little?
I think it was like I cannot say now, but I think it was just like a standard one dose that is done given in many psychological studies just to look at the effects of testosterone. But I can share the link to the study.
For sure. Yeah, because I'm just thinking in like a sports context where some, sports have more like testosterone like supplementation than normal, and I'm just wondering if like those people would have a similar effect because a lot, they abuse it to the point of like it creates permanent deficits in their body in their endocrine system, and I'm wondering if that would have a thing or two, like especially in like the combat sports where they do that quite frequently, even though like they're taking pain all the time, but I guess they're conditioned to be used to that, so who knows. But it's a very interesting effect because now there's like a hormone that's taking place for something that's experienced cognitively, so there's more to be done, I guess, in that sense.
Definitely, I think that's a sport is interesting example. Also because during sport they probably you don't want to experience more pain.
Yes.
But the tricky part with all the hormones is that it's such a delicate balance, and it can be
Hmm.
that by increasing testosterone to a certain extent, you have this effect, but if you go over it, you can have opposite effect. So
Yeah.
that's why you really need to look into the dosages, of course.